Okay, yeah. Okay, so good evening, everyone. So today, we will do the exact same thing that we did last time, in which we presented an interesting case. Okay. Okay. So just, this is the YouTube channel that all the previous presentations are there. Not all of them, but most of them. Okay. So if you wanna take note of it, this you guys are seeing the this bar. You're seeing it or no?
What?
There is like a mute, stop video, like a bar on top here.
No,
no, just
I
mute.
don't see. No,
Okay.
no, nothing.
Okay, good. Okay, so let's keep going. Okay, so this is a 9 years old girl. Now she's 9 years old, who was born with very long QT interval. It was around 600 milliseconds. And as a result, she had functional 2-to-1 conduction, meaning, so this is her ECG, so meaning, the PQRS, very prolonged repolarization. The next P wave that comes in, it doesn't conduct like the ECG that we just show, but not because there's AV node disease or because this atrial beat came in very early. It's because that the ventricle are still repolarizing from the previous beat, so that it's not ready to reconduct again or depolarize again. So when you have a very prolonged QT interval, sometimes babies present with functional AV block because of severe prolongation of the QT interval. So that's an unusual, but does happen, presentation of a significant QT prolongation in babies. Okay, so she was as such. So she had bradycardia with 2-to-1 conduction because of a very prolonged QT interval upon birth. Okay, so as a result, because of a bradycardia, prolonged QT interval, ideally you treat them with at least beta blockers, and because of bradycardia, you cannot give beta blockers. So she had underwent a single chamber pacemaker at 4 days of life, and to allow for beta blocker initiation. However, despite being paced, despite being on treatment, he had frequent torsades du point, and fainting with seizures. So she underwent upgrading of her pacemaker to ICD, okay, epicardial ICD. This was at around 2 years of age. Okay. However, she kept having symptoms in terms of fainting and palpitations and syncope and torsades. So she underwent left cardiac denervation at shortly thereafter at 2.5 years of age. But she remained after this ICD. She had multiple shocks because of torsades. Usually the trigger was fever and any GI sickness. And at the time she was in bisoprolol, lecanide, labetalol, spironolactone for potassium sparing effects, and being paced. Okay, so now I inherited this patient after all this had already happened. So this is now back in 2018. I do see this patient for the first time, and first thing I did, I switched her to nadolol from bisoprolol, and I'll say why later. So we changed the beta blocker therapy, and I added magnesium because I was desperate, and I increased her pacemaker rate to 90 beats per minute. Definitely she improved with the addition of nadolol, magnesium, and increasing pacing. However, she had at least, she did well for 1 year, but then she had another episode of torsades. However, it was non-sustained, and she was vomiting at the time. And mom told me that when she fainted, it was 2 hours before her next nadolol dose. So it was probably trough level of nadolol, but she was also vomiting. So the absorption of the drugs were probably suboptimal. Anyway, so because of repeated symptoms and the pace, and this is her torsades, by the way, she does have polymorphic and often non-sustained, so she wakes up, but sometimes sustained, so she gets a shock. Okay. Her ICD was nearing elective replacement time, so we thought about her extensively, and we decided to add an atrial lead to her system replace her ventricular leads because she had high thresholds, add new coil leads because the previous coil leads, I'll show the x-ray in a minute, because the previous coil leads were, the position of them were not ideal. And we did also right sympathectomy. So we did previously left sympathectomy, and now we did right sympathectomy. This was 2 years ago, exactly in August 2019. And this is her x-ray. You can see my mouse or no? Let me see.
Yes, yes.
Yeah, you see, yeah? Okay. So these are this coil lead. So let me orient you. This is the generator, of course, the ICD. Okay, this is a high voltage lead, meaning this is where the the shock is coming from. Okay, so this is one lead, and this is another high voltage lead, and this is when she had the implant. So this lead initially was around her cardiac apex, and she had a subcutaneous lead that is around surrounding the heart, so that ideally you want the coil lead to be and the generator to be hugging or in between the heart, so that the cardiac mass is between the shock vector. Okay, but however, with time, as she's growing, these, especially the subcutaneous coil lead, like she's lengthening, so it remained in place and shifted a little bit downwards. So it's not ideal. So should she require a shock, the vector now is between these two and the generator. So the most cardiac mass is outside this vector. So I was worried that, maybe in 1 or 2 or 3 years, she would even lengthen some more, and these coil leads would be displaced inferiorly, and the heart would go superiorly, and then, she would not respond to any potential shock. So we added a third coil lead, which is this one, and we canceled these two, so that, previously the vector was between coil to generator. So coil generator. Now we canceled these two, so now it's from this coil to the generator, and as you can see, the heart is between the coil and the generator, so that's good. Yeah, and this is her atrial lead, and this is her new ventricular lead, and this is her old ventricular lead. Okay. Okay, so she has so much, metal in her chest and abdomen, and this is one of the issues with the devices in pediatrics, of course. There's so much metal in them. At some point when they are 40 or 50, there is so much you barely have space to implant new ones. But anyways, in terms of her family history, she's a product of a consanguineous marriage. Her parents are first-degree cousins. She has very significant family history. So her dad, who died at 37 years of age, he died suddenly after having dinner, no specific trigger. He was very active, a sports personnel. He runs every day, according to her mom. Very, very healthy individual, but suddenly died after dinner. She has 2 aunts who died at postpartum, shortly postpartum, 4 or 5 months of age after giving birth. And one of them died after phone ringing, like she suddenly, startled from a phone ring. She also has a first-degree cousin who was born with similar presentation, had AV block, required pacemaker. I don't have the details, but definitely had functional AV block, pacemaker, and had fever, illness, and died suddenly at 3 years of age. So probably similar to this patient. She had a great aunt also who died at 38 years of age, postpartum as well. She had 2 second-degree cousins. One died postpartum and one died during pregnancy. Okay, so and then she had half an uncle who died suddenly at 62 years of age while asleep with fever. So there's definitely fever triggers. Postpartum pregnancy is very significant in terms of triggers for sudden death in this family. So her mom, so the known affected family members that we know of, meaning they are gene positive, her mom has subcutaneous ICD, and we talked about subcutaneous ICD previously. We can discuss it later, but mom has that type of ICD, and she definitely had an appropriate shock. One day she was NPO for surgery, and after surgery she had a shock because of torsades. So mom definitely has the disease as well. And her brother, who is on nadolol, he's asymptomatic. He's now he's around 8 years old now, and this is his ECG. His QTC is around 450, 460, 440, and his ECG is very unremarkable. However, he does have the gene, mutation that this patient has. But yeah, this is an example of same family, one with very sick presentation and one with not as sick of a presentation. We will discuss this, why is that, in a minute as well. Okay, so obviously she has long QT syndrome. The question is, what type of long QT syndrome that you guys think of? Do you know, anyone knows what type of long QT syndrome she might have? Anyone want to say something, or
Better to proceed.
okay, so I don't know what's okay. So okay, I don't know what I did. Okay, sorry. So she back in 2015, she had genetic testing and showed long QT type 2. She was homozygous, meaning she had two both genes that are mutated, because remember, her both mom and dad are cousins, first degree cousins, and both are heterozygous for the mutation, and she unfortunately inherited both mutations. Her mom and her brother are heterozygous, and hence probably less sickness. They are less diseased because of the heterozygous inheritance, versus this patient, index patient, who is homozygous. Okay, so this is her exact mutation. This is in the KCNH2 gene, and this is a gene known for long QT syndrome. So this is her genetic report. It was that specific mutation was labeled as pathogenic. And we talked about genetic testing before, and just really quick, it's pathogenic based on because this specific mutation was not present in normal population databases, meaning if it's not present in normal, it's very likely that that it's not a normal mutation, right? It is when they tested, there is a lab testing that predict the protein function with the mutation. That lab testing showed probably damaging to the protein function and structure. So that's again pointing toward pathogenic mutation. There are many published mutations within the same area that causes disease, and so forth. So there is an art, there is so much science behind labeling a mutation as pathogenic or likely pathogenic or variant of non-significant or so forth. So these are the reasons why genetic companies label a mutation as such. Okay, so but in this case, there was significant evidence of very pathogenic mutation. Okay, this is I did not show you her ECG yet. I don't have her ECGs back when she was a baby, except because they were shaded away. They're not very clear. I showed you a couple. This is one of the recent ECGs. However, she was on flecainide at the time, high dose flecainide and beta blockers. So this is the high dose flecainide beta blockers are it probably explains why she has first degree AV block, and explains why her QRS is wide-ish because of the high flecainide. You remember, flecainide is a sodium channel blocker, and if you want to see the flecainide effect on ECG, usually it widens the QRS because phase 0 of action potential, if you remember, phase 0 of action potential. So the QRS is phase 0 of action potential, and then the rest of the phases are the repolarization. So the flecainide decreases the slope of phase 0, right? Because sodium channel works in phase 0 and it blocks sodium channel, so the depolarization slows down and the QRS widens. Okay, so with flecainide, if you give someone a good dose flecainide, usually the QRS widens a little bit. Okay, so this is the case for her. Anyways, and definitely her repolarization is abnormal. If you see the repolarization looks very long, ugly. T waves are abnormal, inverted here, and definitely long repolarization. But this is during drugs. So I don't have a nice example of her ECG without drugs, because she was on drugs since the beginning of life. Anyways, so This case represents a very significant or extensive death in a family with long QT syndrome, which is not very common. Usually there is not as much of death in long QT syndrome families, but that's an interesting case. So long QT syndrome is potentially fatal arrhythmogenic mutation. There have been 17 genes implicated mutation 17 genes that might cause long QT syndrome. It results in, of course, QT prolongation or abnormal repolarization. It affects around 1 in 2,000 individuals or 1 in 3,000 individuals. So this is the most common channel mutation in cardiology that we see. So most of our channelopathies are long QT syndrome. So it's relatively common, okay? So 1 in 2,000, so it's not very rare. So that's why we see it very often, okay? Specifically for long QT type 2, the mutation, as we said, is in KCNH2, which is a gene that produces the potassium channel and potassium ion channel, and it leads to reduction in potassium exiting from the cell. So if you remember, again, this is phase 0, and then this is the repolarization. Potassium normally exits the cell so that the cell goes back to being negative in charge, okay? So this slows down that process. So then the repolarization is slowed down, okay? So because potassium exits, it slows down the exiting of potassium. So then the cell remains positively charged for longer period of time, and hence QT prolongs, okay? Makes sense, guys, so far? Or am I quick? Okay, I'm trying to be quick because it's very scientific. It's not very clinical yet.
It's good.
I worry that I bore you, but it's an important piece of information that you need to know. Okay, so as an example here, this syndrome is very challenging because there is incomplete penetrance, meaning the patients with the exact same mutation, siblings with the exact same mutation, one of them might be disease with very abnormal ECG, and one of them might have a very normal ECG, but you cannot tell but only on ECG because of the incomplete penetrance, okay? So the ECG may or may not show QT prolongation, and the patient may or may not have arrhythmias, okay? Some people remain asymptomatic throughout life, okay? So, and for example, her brother is, as of today, he's I think around 9 years old, he's still asymptomatic, and he might remain asymptomatic for a while. If ever he might never develop symptoms, we don't know, because his QT was never very prolonged, okay? So not all patients are alike, even if they have the exact same mutation, okay? So how do we risk stratify patients within the family? Before saying that, so when you have a patient with definite long QT syndrome and you screen the siblings, and the siblings ECG is normal, it doesn't mean that they don't have the exact same mutation. It might not just mean that this patient is, still has the mutation, but for some reason there's incomplete penetrance, okay? So whenever you have a patient with long QT syndrome, you perform genetic testing, and if there is a positive genetic testing, then you screen the family with the genetic testing, not with ECGs. You can still screen them with the ECG, but ECG, if it's normal, doesn't mean that he doesn't have the disease, okay? So always you should stop the phrase, you see this family and you say, we don't need to do genetic testing in you because you have a normal ECG. That's wrong. If you have an established gene mutation in a family, you should screen all the family members genetically, not otherwise, okay? Okay, so now how do you determine which patient might be at risk, okay? So, during childhood, usually males are more at risk of having symptoms compared to females, okay? Also, if you have a QTC that is more than 500, this is a risk factor, okay? Or if there is history, syncope, there's prior syncope history, okay? Especially if it's a recent history, okay? So male, gender, prolongation of the QT and syncope is always a risk factor regardless of age, okay? But the gender, usually in young people, males are more at risk, but then there is a gender flip or divide at roughly 18 years of age or 20 years of age. When then females get to be at higher risk. Okay, so pediatric age, usually males, a little bit, beyond pediatric age, females get to be at a higher risk. Okay, and the mutation itself, the specific type of mutation, meaning is it a missense or not a missense? Is it in the mutation itself? Is it in the transmembrane portion of the gene of the membrane versus or the terminal portion of the membrane? So if it's in the transmembrane portion, usually patients are more at risk of having symptoms. If it's in the terminal portions or the tails of the ion channel itself, usually they are at less risk of having symptoms. If there is loss of function or severe dominant negative means severe loss of function. If there's severe loss of function, of course, they are more at risk. So the specific type of genetic mutation is also a risk factor. Okay, and in terms of types, usually pediatric age, long QT3 is a risk factor. Is patients with long QT3 are at higher risk of having cardiac arrest or sudden cardiac death at extremes of ages, in pediatric age and, when they are beyond 41 years of age. And during this middle age group, usually long QT2 is, where the highest risk for having symptoms or having acute cardiac arrest. Okay. But, complexity aside, clinically, usually we focus on is there prior syncope and what is your QTC. Okay, if your QTC is almost always below 500 and you never had symptoms, you are at low risk. Okay, if you have a QTC that is prolonged or prior syncope, of course you're at higher risk. Okay, and of course, if you had like a CPR or had torsades or had, near cardiac death, you're at the very, very high risk of having repeated attacks or death even. Okay, so clinically we focus on these factors. Okay, so like we said, it's a genetic disease inherited usually in an autosomal dominant pattern. Okay. And this is called Romano-Ward syndrome. Okay, I mean, you have read Romano-Ward syndrome before, so this just means it's an autosomal dominant long QT syndrome. Okay, so however, rarely there's an autosomal recessive pattern of inheritance, and often associated with hearing deficit, and this is called Jervell-Lange-Nielsen syndrome. Okay, this is usually long QT type 1. With hearing deficit and autosomal recessive, like meaning the patient has both two mutations. His mom and dad are asymptomatic, but the patient is symptomatic and with hearing deficit. Okay, so this is Jervell-Lange-Nielsen syndrome. Okay, very, 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 very rarely there is the patient has a autosomal recessive inheritance, however, without deafness. Okay, but this is very rare. Usually there is deafness. Okay, and then sometimes there's non-cardiac involvement. There is a syndrome called Anderson-Tawil syndrome, in which they have periodic paralysis, skeletal abnormalities, or Timothy syndrome, in which they have autism and dysmorphic features. And by the way, we have Anderson-Tawil family. We do have a patient with Anderson-Tawil in my clinic. She doesn't come very often. She's not very compliant. This family is not very compliant, but we do have a family with Anderson-Tawil syndrome. I don't have a family of Timothy syndrome yet, but I'm sure we'll see it one day. Anyways, so just to remind you, long QT syndrome has been described, back in 1957, but only, clinical testing is only established in 2004. So this is very, in terms of genetic testing, is very recent. Okay, and guidelines only had been written back in 2011. So it's relatively new disease in terms of understanding it. Okay. And like we said, there are 17 genes involved, but most long QT syndrome patients are either type 1, type 2, or type 3. Like 80% of long QT syndrome patients, or even more, are either type 1, type 2, or type 3. Okay, so this patient is type 2, KCNH2 gene, but most patients are actually type 1. Like around 40% long QT patients are type 1, okay? But this family again is type 2, okay? In most patients, when you have an abnormal ECG, you think the phenotype is definitely suggestive of long QT syndrome. Most patients will have a positive genetic mutation, like around 80% of them, okay? So the genetic testing would provide a high yield, okay? Versus, for example, Brugada, it's a very low yield genetic testing, but long QT syndrome, it's a very good genetic testing disease. It's a very good disease to test for genetics, okay? And once you have something positive, you cascade screen the family. You specifically test that specific gene mutation in first degree family members, okay? And like we said, the only thing that can rule out long QT syndrome in an established family with genotype positive long QT syndrome is negative genetic testing, okay? So again, if the sibling has normal ECG, it doesn't mean he doesn't have long QT syndrome. We have to make sure that the gene mutation that's present in the index case is negative in that individual, okay? Make sense so far, guys?
Yes.
Yes? Okay. Okay, I don't know why whenever, okay. So of course you have to be aware of variant of unknown significance. So you know, occasionally when you order genetic testing, the mutation, you know, the genetic report comes back with a mutation that is of unknown significance, and then you have to research that mutation and research the phenotype, and then decide whether you believe that variant is significant or pathogenic or non-pathogenic. You have to decide for yourself as a clinician. You get this report, you read about that, you know, mutation, and then you know the family very well, you know the patient very well, and you decide whether this mutation explains the patient symptoms or doesn't explain the patient symptoms, okay? Anyways, you guys don't deal with the genetic report, so it's just really quick, be aware of this variant of unknown significant gene reports that might be confusing and annoying, and you might overreact to it, and then you might do harmful things to the families. Meaning, if let's say you have a patient who you did genetic testing for a silly something, and then it came back positive for you know, it came back VUS for a specific mutation, and then you believe that genetic report, and then you treat the patient for something that he doesn't have. You know, you see my point? You might overtreat someone based on genetic testing. So you have to be careful ordering genetic testing, okay? Okay, so now let's, you know, again, this is all, you know, basic science. Let's go to clinically what we do. So when you have a patient with, you know, ECG that is suggestive of long QT syndrome, how can you diagnose this patient? Okay, so there is, of course, recommendations or on diagnosis of long QT syndrome. So there is something called long QT syndrome Schwartz risk score, and I'll say it in a minute here, but just there's a risk score that you could you know, calculate. Otherwise, if there is a pathogenic mutation, then bingo, you have the diagnosis. Or if the patient indeed have QTC of more than 500, in the absence of secondary causes for long QT prolongation. For example, patient has, you know, hypokalemia, and so that with the QT prolongation, then you correct the potassium, the QT normalizes, that's not long QT syndrome, okay? Or for example, if the patient is getting some drug that prolongs the QT, you stop the drug, the QT normalizes, that's not long QT syndrome. You must have the long QT interval without explanation for that prolongation, okay? Or you can have QTC between 480 and 499 with unexplained syncope or symptoms that might suggest, you know, arrhythmias, okay? Or, you know, torsades, okay? So these, I mean, you don't have to read this, it's very small font, I know, but just so you know, there are so many things that might artificially prolong your QT interval, you know, metabolic disorders and many drugs that might prolong your QT interval, and, you know, other factors such as neurological insult, okay? So for example, we have so many CP patients, and the CP patients, of course, they are often bradycardic, plus their ECG would often show QT prolongation. And then they phone us, you know, this patient has long QT syndrome. most likely, no, this patient has CP and the QT prolongation secondary to the neurological insult, not the patient has CP plus long QT syndrome. Okay. So I get this call very often that, CP patient with QT prolongation. Okay. Otherwise, if you have a prolongation of the QRS, for example, you have right bundle branch block, left bundle branch block, ventricular pacing, your QRS is wide, and then you're by default, because the QT interval is from the QRS to the T. If you have, I don't know what I did here. Yeah, here. If like if you have a wide QRS, of course your QT interval will prolong, right? Versus if you have short, narrow QRS, your QT interval would shorten, right? So if you have a wide QRS, by default, your QT value would increase. So you have to, measure it with caution. And I'll explain what you might do in a minute as well. So that's the score I mentioned. That's the Schwartz score that is mentioned in the recommendation. So, there are points. And if you have a QT beyond 480 milliseconds, you get 3 points, for example. You do a stress test, you have QT prolongation upon recovery from exercise. This is why I do exercise stress tests for my long QT patients or my suspects for long QT syndrome. I do it myself because I exercise them and then I wait for roughly around 8 to 10 minutes after exercise, and I do repeated ECGs and make sure that their QT interval doesn't prolong upon recovery, which is a very abnormal. Okay, if they have torsades, they have T-wave alternans and so forth, syncope and deafness and so forth. Okay, so these are the points, and if you score above 3.5, you have very high probability of having long QT syndrome. Okay. And then you guys know what's T-wave alternans, right? Like the T-wave that flips. So this is a positive T-wave, right? A negative T-wave, positive T-wave and negative T-wave, right? So it's clear. Sometimes it doesn't have to flip. It just, so this is a positive, prominent T-wave and then less prominent and, smaller T-wave. So any variation in the T-wave, beat to beat, this is called T-wave alternance. Okay, so this is a very bad sign. This is a sign of impending arrhythmia that might, torsades, impending torsades. Okay, so Dr. Schwartz himself, who invented the score, did say at some point, like he, you don't have to measure the QTC, you just look at it. Meaning, if there's a skill that you would develop with looking at so many ECGs, you would know what abnormal T wave that is suggestive of QT syndrome. Okay, so the look of the QT interval, not just the measuring of it, is also as important. Okay, so so again, if you see that this ECG with T waves that are changing beat by beat, even if it doesn't measure very long, you have to be very suspicious. Okay. And then these are the QTC values that people, definitions of normal, borderline, and prolonged. Okay. Okay. So, normal people.
Sorry,
Yes.
sorry, Mohammed. Is it? I thought it is sex related. Is it the male 460 and female 470, or am
I will speak about this in a second. Okay.
Okay.
Okay. So the normal, so this graph represents normal distribution of the QT values, both in male and female. Females are slightly longer a little bit. Okay. So that's normal distribution. And if you pay attention, normal distribution for females and males, females especially, it might extend all the way to 480. Okay, and then males might extend all the way to 470. Okay, so that's normal distribution of normal males and females. Okay, and this is a graph. This second graph here is a distribution of patients with definite long QT syndrome, and as you can see, some definite long QT syndrome have QTC of as low as 360. Okay, so imagine someone with long QT syndrome with a QTC of 360. Okay, so So this is why it's a little bit confusing. Just measuring the number itself doesn't, help you with the diagnosis. You have to look at the entire picture, because you might see a patient with definite long QT syndrome with a normal QT interval, or even, shortish QT interval, okay? And you might have a patient with, normal individual with a QTC of around 480 or 470, but he's still normal for, for him, okay? So there is an overlap. So there is this shaded area, it's all overlap, okay? So there's an overlap zone between normal and abnormal. So that's a little bit, that's what makes it tricky, okay? So what this is, Ayman, this is to answer your question. So 470 is the 99th percentile for males, and 480 is the 99th percentile in females, okay? This is post-puberty, and pre-puberty, it's below 460. So in pediatrics, roughly, or the beginning of, in the first 12 years of life, ideally, QTC is below 460, okay? But again, there is a spectrum, there is bell-shaped curve, and you would see a normal patient with a QTC of a little bit above 460 in pre-puberty in both genders, occasionally, okay? And so this patient, you have to study him very well, and you have to decide for yourself, should I pursue long QT syndrome, suspicion and testing, or should I not? You have to make this is a clinical decision that you have to make, okay? So again, and if you see this curve very nicely, so if you use 480 as your cutoff, around 40% of definite long QT syndromes would fall below 480. So around 40% of long QT syndrome patients are actually, have concealed long QT syndrome, hidden long QT syndrome, okay? So that's why many patients are, you do ECGs and you will miss many actual long QT syndrome patients based on ECG, but that's okay, because often if they have QTC of less than 500-ish, less than 500, usually they are largely asymptomatic, okay? Yes, they have the disease, but they rarely manifest the disease. Make sense, guys? Okay. Okay. So just purely measuring QTC and focus on one number and then you call them long QT syndrome or not, that's not the case. There is a score. There is, like the guidelines, again, go back to the guidelines. If it's above 500, then you can call him long QT syndrome. But if he's below 500, you need to have symptoms with it. Okay. Okay, guys. Or genetics with it. Okay. Okay. So, okay. So often I get a call, this patient has 475 QTC. This is long QT syndrome. You have to, pause, you have to think twice before labeling someone with long QT syndrome, just based on one ECG number. Okay? And then often that measurement is done wrong often as well. So this is the most important slide here. How do you measure QTC? Okay. I'm just checking 943. Okay. So how do you measure the QT? So back in the day when I was a fellow, we used to do, this is ideally what you should do. So that's, you have an ECG, you draw a line, from P to the next P, okay? So that this line intersect your PR interval and your TP interval. So this line should intersect your isoelectric segments, which is usually the TP or the PR segments, okay? So you draw a line intersecting your isoelectric segments, and then you look at the T wave and you transect that line with this most acute or sharpest angle within the T wave. So that's your line here, and then you see the T wave, and then this is the steepest line within the T wave, and then you draw a line here, okay? And that line should be within the T wave, not outside the T wave, okay? So this line should be in the inner portion of the T wave, not the outer portion of the T wave, okay? So you intersect, and that's your QT interval. If you see a U wave, you ignore the U wave, okay? So when you do this, you often, if you don't do that, you often exaggerate your QT interval, okay? So again, draw a line and then draw another line and you intersect them, and that's your QT. And then you measure, of course, from the onset of the Q to the onset, to the intersection, okay? And then you measure the preceding RR triple, okay? The preceding RR triple, okay? So this is called teach the tangent method, okay? You know, if you look, if you study any QT or ECG book, this is how they teach you how to you know, measure the QT, okay? But often no one does that, you know, that's the problem. So you have to get used to doing it. When you're suspicion of something, you're suspecting, sorry, long QT interval, you have to double check using this method, okay? So we did mention the U wave. Of course, so this is an ECG, there's a U wave here. Of course, you don't include it, okay? However, so if the U wave is more than 50% amplitude-wise from the, so if the U wave is 50% and above in terms of, you know, amplitude of the T wave, you include it. So for example, so that's a T, that's a U. That's, you know, that's a very big U wave, right? So in this case, the QT here extends all the way to here. So that's your isoelectric line. And then you stop here because that U wave is significant, right? Here, for example, that's a T and that's a U. So that U is included. So that's actually, we call this bifid T wave, not a U. But if you want to call this a U, you have to include it within the QT measurement. Why? Because it's a bigger than 50% of the T wave. So you do this line again, you do this trick, and then you stop here. You understand? So you don't go all the way to here. When you do this method, you tend to shorten the QT that you otherwise would measure. Make sense, guys?
Mm-hmm.
Yeah. Okay. So U wave could be seen in many different in electric disturbances, but also could be seen normally in normal individuals, and is often seen in V2 V3. Very often you see U wave in V2 V3. Hence, when you measure the QT interval, people usually avoid V2 V3. Usually they do lead 2 V5 for sure, plus the other leads, but lead 2, lead V5 are where, when people measure QT, when we have these normal distribution of QT in measurements in normal people, usually people use lead 2 and lead 5, so V5. So try to focus on lead 2 and V5, and then look at everywhere, of course, but lead 2, lead V5 are your leads of choice, and then everywhere else, but try to avoid V2, V3, okay? Okay, and this is an example of a study that was done at Mayo Clinic, where, they have a very large long QT center there. And, for example, they got referral of 176 families with long QT syndrome. And, out of this 176 families, actually around 69 of them, they did not have long QT syndrome to begin, like interval to long QT or prolonged QT interval to begin with. So it was an erroneous measure. It was usually because of inflation of the QT second QT wave inclusion, or because someone had vasovagal syncope and people get over worried. Okay, so and this is in a developed country in the in the US. So imagine otherwise. So long QT syndrome is very often overdiagnosed. So because of overassessment or inclusion or inappropriate or improper measurement of the QT interval itself. Okay. So again, the average when they got referral, the average QT that was measured was 508, but when they did their remeasurement, that was around 444. So that the average was above 500, from the referral centers, but when they measured the exact same ECG, the average came down to 444, which is very significant, right? So again, so this tells you that people are not measuring QT very well, okay? And we have our own data here. So we did the study, and we provided this ECG to people, and this is as long of a QTC as you can get. Okay, this is like I think it was 620 milliseconds, and around 42% of physicians said there's no long QT interval. Okay, so that's crazy number in terms of how can physicians not know or not recognize that this ECG does show prolonged QT interval. We did not even ask them to measure the QT. We just said, is there QT? Well, we didn't say. We just said, just note what's abnormal. And 42% did not realize there was a QT prolongation in this patient. Okay, and this patient happens to be who fainted so much, had torsade so much, and he tried to die a couple of times. This specific patient. So it's a very important something not to miss. Okay. Okay. And then another study here, even specialists, heart rhythm specialists, more than 1/3 of them did not calculate QTC very well. Okay, so even EP physicians, I mean, of course, like cardiologists, they did not do very well. EP physician, they did better, but not great. And there are people who are QT experts, and then they did measure it correctly using probably the tangent method. Okay, so besides the tangent method, what tricks would you use to assess the QT interval? Again, we said avoid V2 with V3, focus on lead 2, lead V5. We said look at the ECG and measure only the QT. So for example, this is your QRS, okay? And this is your T wave, okay? And then your QT measures, you just measure it, it's like around, let's say 400, okay? Okay? And then the machine, the machine would show you what is the QT, right? And what is the QTC, right? So if the machine tells you the QT is 400, then the machine got it right. And then the QTC, just the machine doing math. And then, by measuring RR interval and square root of that. And then the RR interval is usually a big deflection, and the machine always gets it right. The rate of the ECG is almost always right. So when you see me sometimes measuring QTC very quickly, because I do this. I do measure the QT only, and I check it with the machine. If I match the machine, I know that number that the machine is providing is is accurate. If the machine QT is exaggerated, then I know that QTC would be exaggerated. So then I'm less worried. You see, so I don't measure the QTC each and every time. I do this in my because you do see many ECGs, and you don't have time to measure each and every QTC in each and every ECG. Also, if the QT is less than half the RR interval, then your QTC would be less than 460. And then that this patient is very unlikely to have long QT syndrome, although he might, but very unlikely. Okay, he's definitely not at risk of arrhythmias that you would think you would think he will at least not be at risk of arrhythmias in the near future, at least. Okay, so another thing, you just look at the QT and make sure it doesn't extend beyond the half RR interval. Make sense, guys? So this is your next QRS here. So that QTC ends, if it ends beyond the 50% mark, then you have to measure it and make sure it's because it would most likely be above 460, and that's that you will receive points using the Schwartz score, and then you might think of QT syndrome. Okay. However, if it's below 460, you think less of long QT syndrome. Okay. If you have sinus arrhythmia, you take the average, meaning you measure the shortest RR interval, the QT that is subsequent to the shortest RR interval, and you measure the QT that is subsequent to the longest RR interval, and then you take the average of both. You don't. Some people what they would do is they look at the shortest RR interval, and then they measure that QT, and then it's obviously would be longish, and then they would overreact to that ECG. Okay, makes sense, guys? So far? Yeah. Everyone makes it. Most people are quiet today, so either
No, it's okay. It's okay. It's interesting.
Super duper clear, or I'm losing people. Okay. So I'm assuming I'm super clear, but I'm not very sure. Anyways, okay. And know that if someone is very bradycardic, so for example, an athlete, or someone is very tachycardic, for example, baby, the QTC would not be very accurate because this math that we do is works best between 60 and 100 beats per minute. Okay, so in babies, you might the QTC is always a little bit generous in babies, and we don't need to overreact to it, because again, that calculation that we use doesn't work good for heart rates above 100. Okay, so so in babies we use we use family history, we do parents ECG, we repeat the ECG after 6 weeks, 7 weeks, 2 months, and make sure the QTC shortens a little bit, because as the heart rate comes down, the QTC shortens. And then if it's within range, then I would just dismiss it. Okay, and if the parental ECGs are normal, there's no family history of concern, there's nothing that suggests long QT syndrome, I don't even think about it. Okay, if you have wide QRS for some reason, again, if you have wide QRS, so what you do is you just let's say your QRS is 150, you just sorry, your QRS is 150, for example, or 200. You minimize 100 from it, and then so this extra 50, you just minimize it from your QTC. This is the formula that people might use to adjust for wide QRS. But it's very, 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 very unusual to have a patient with long QT syndrome with a wide QRS, because remember, QT, prolongation of long QT syndrome is a disease of repolarization. Your depolarization is usually normal. It has nothing to do with your depolarization. So your QRS would be intact, would be just normal. Okay, if you have wide QRS, because of, for example, someone who underwent VSD closure and has right bundle branch block, then of course you'd have right bundle branch block. You often try to assess the ECG prior to surgery. Okay, because these patients almost always have ECGs prior to surgery, so you study that ECG prior to surgery, and if it was normal, then I wouldn't worry about it. Okay. If it's, for example, you're very suspicious, its QRS is very wide, but the QTC looks wide, you do this math, and if it's significant, then you use your Schwartz score, you take good family history, you do parental ECGs, and you go from there. Okay. Also, congenital heart disease, we have many patients, of course, with congenital heart disease. Very, 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 very unusual that you have a patient with congenital heart disease plus long QT syndrome. Like in Kuwait, I don't have any. In the US, I actually did a study, me and others, my mentors, we did a study. We tried to to figure out how many patients with long QT syndrome does have congenital heart disease, and we only found 11 patients out of, it was a center with 500 surgeries a year, many patients. We only have 11. Okay, over like 10 years. Okay, so it's a very, very rarely that you have congenital heart disease patient plus long QT syndrome. Okay, so again, our patients, most of our patients, most of our congenital heart disease patients, they will never have long QT syndrome. Okay. Okay, so when you again, so back to the number itself. So the number itself, let's say the ECG looks, the QT interval or length looks very normal. One other trick that you should do as well, you study the T wave. And if the T wave, if there's T wave alternance, of course, this is alarming. Usually with T wave alternance, you already have QT prolongation anyways, but if the T wave changes, that's usually not a good sign. And if there is if the T wave looks like this, there is like indentation or biffid within the T wave, like here, this ECG, see this ECG? There is like another dent within the ECG. It looks like there is two waves within the T wave. Okay, so that's a sign of abnormal. This could be a sign of long QT type 2. Okay, if you have an ECG with very prolonged ISO, ST segment, like very long ST segment, then the T wave, late peaking of the T wave, that could be a sign of long QT3. Okay, and then if you have an ECG with a very broad-based T wave, like the T wave starts almost immediately after, there's no ST segment, and then T wave starts almost immediately and does like this, even if it measures short, you know, and there's family history of something funny, you might be suspicion, or is this patient, you know, one of those patients with normal QT interval, but long QT syndrome, you know, this is how you be smarter about identifying long QT syndrome patients. And this is where this statement comes from. You know, you don't measure the QTc only, you should look at it, okay? So always look at the QT interval, the T-wave morphology, and make sure it looks normal, you know, to you, okay? Okay. Also, when you take history, you have to be detective. You have to ask when someone tells you, you know, I had syncope, you have to ask why, where, when, what happened, you know, where you sick that day, and so forth. How long was the syncope? Did you have seizures? Someone did CPR on you? What was the trigger, and so forth? Often people call me, you know, we have this patient who had syncope, and full stop. You know, this is not, you know, good enough. We need more, you know, because this could very well be vasovagal syncope, and I don't need to care about, right? So not every syncope is the same. So you have to take good history when it comes to syncope, okay? For example, swimming is a very known trigger for inducing long QT1 torsades. Okay, if someone with long QT type 1, swimming is usually a trigger for them. If you have someone with long QT type 2, startle is a trigger for them. If you have someone with long QT type 3, usually sleep is a trigger for them. And then pregnancy is usually a trigger for long QT type 2. So back to our family, if you remember, most of our death in this family was during pregnancy, right? Postpartum, remember? And postpartum is very significant factor for long QT type 2, okay? So, and our family displays that very well, okay? So pregnancy and long QT type 2 especially, they don't, you know, when females are pregnant or they deliver and they are long QT type 2, they are at risk of having symptoms. And that's why, if you remember the graphs, females after 18, 20 years of age, they get more symptoms because they get pregnant. Pregnancy with long QT syndrome, they don't go along very well. They might have symptoms during pregnancy, okay? So definitely pregnancy is an important factor for long QT syndrome in general, but type 2 especially, okay? When someone tells you exertional, or, you know, meaning, or mid-exertion, meaning someone is actively running, and suddenly collapse, that's a very bad sign. Versus someone is running, and then he tells you, I got tired, I stopped, and then I fainted. That's not as concerning. If someone is running, suddenly collapse, that's very concerning. If someone is running, playing soccer, but then he rested because he was so tired, and then he fainted, that could be very well vasovagal, okay? So not every exertional, you have to again dig into the history. What do you mean by exertional syncope, okay? And then if someone tells you, you know, alarm bell went off and I fainted, that's not a good sign. If someone tells you I fainted after pregnancy, not a very good sign, okay? Okay, so history and ECG are very important, okay? So now you diagnose this patient, how do you manage him, you know? So obviously you have to, you know, patients, long QT patients should be very well hydrated, their potassium levels should be normal, magnesium levels should be normal. So they, in general, diet or GI upset is often a trigger. So, you know, make sure they're always hydrated and healthy. You know, if they are long QT type 2, you know, alarms, they should try to avoid alarms. Of course, it's not very easy. You know, there's a website that you always have to tell your patients, check, you know, qtdrugs.org or crediblemeds.org. This website documents all drugs that might prolong your QT interval, okay? So especially for, well, not especially, but, you know, the patient with long QT syndrome, they all, you know, whenever they are prescribed a medication, they should always tell their physician, by the way, I have long QT syndrome, check that website. And often the physicians are not aware of this website. So I tell my families, you check it yourself. You know, I try to teach them. But, you know, of course, you know, sometimes they, you know, it's difficult to teach them, but at least I tell them, write it down, show it to the provider, make sure he knows that not every drug he should take, okay? So I give them, sometimes I print the list. It's an extensive list. And I showed you that list, a couple of slides ago, but every week or month or so, this list keeps changing, okay? So there's no point of printing it. They should check it online, it's better, okay? Fish oil apparently helps low QT syndrome patients, especially if they are into, complementary alternative medicine. I tell the families, especially if the like in this family, for example, I told mom you should be taught CPR, and she knows. She has CPR certificate or BLS certificate. So families with significant risk factors, I always tell them you have to train yourself to do CPR. Not just you, family members, all family members that are living with the patient. Okay, if they want to do sports, you have to it's a shared decision making, meaning if the patient has the gene but ECG is almost always normal, they probably can play sports like they want. It's not a big deal. If the gene positive but phenotype positive, however asymptomatic, they can probably still play sports, but you have to caution them. You have to make sure there is automated electrical defibrillator there. The gym or the trainer knows how to do CPR or how to use that machine. Otherwise, it's of no use, right? And if there is symptoms, you probably should avoid sports, okay? Especially low QT1. Low QT1 is is with exertion, okay? So low QT1, their activity is not the greatest for them, or like physical activity. Type 2, type 3, they might tolerate activity better than type 1, okay? Okay. So back to the recommendation or the guidelines. Of course, beta blockers is your drug of choice, your initial drug of choice, and it's class 1 for all patients if they are above 470, and it's class 2A if for the patient less than 470. So every patient with long QT syndrome, I usually recommend beta blocker in pediatrics. Now, when they get to adults above 40, for example, I might, and they never had symptoms, the QTC is almost always normal or borderline, I might stop the drugs because the risk goes down with age, okay, in general. And then, side effects from beta blockers during, a marriage period and stuff, there might be significant side effects. So pediatrics, I don't worry about side effects, but once they are 25, 30 years of age, I might consider not giving, starting therapy or stopping the therapy, okay? But guidelines wide is class 1 if it's 470, class 2A if it's less than 470, okay? Of course, if it's symptomatic, you should treat them regardless, okay? With beta blockers, of course. And then for beta blockers, of course, there are so many beta blockers. And not all of them apparently work as good for long QT syndrome. So, nadolol, we like nadolol for long QT syndrome, and propranolol for babies, but nadolol for beyond infancy is the best for long QT syndrome. Metoprolol is not good, okay? Atenolol, there are conflicting reports about atenolol, but metoprolol, almost everyone agrees, is not the best for long QT syndrome. Bisoprolol, I don't think there are studies about bisoprolol. So bisoprolol, I don't know, but nadolol is your safest drug of choice, okay? So I always try to go for nadolol. And for our patient, if you remember, she was on bisoprolol and she wasn't doing very well. When we did nadolol, my impression that she improved so much, okay? So I do believe that bisoprolol is not the greatest for long QT syndrome, okay? But there are no studies that I did not look super well, but I don't think there are studies for bisoprolol. Anyways, for long QT type 3 specifically, propranolol is better than nadolol because it has, long QT type 3 is a sodium channel mutation, not potassium channel mutation, and propranolol when you give very high dose of propranolol, it affects the sodium channel as well. So that's why it's better for long QT type 3. And there's a drug called Maxility, which unfortunately we don't have. I'm trying to bring it, I'm trying to order it for many years now, but we don't have yet. But it's a very good drug for long QT type 3. And flecainide is also good for long QT type 3. Our patient, she was on flecainide because people were desperate, because she keeps having torsades and nothing is working for her. And they threw flecainide on her, but probably did not do much for her anyways. And I think I forgot to mention, after this right pathectomy, we stopped all her drugs except nadolol, and since August 2019 she has nothing. Okay, so right sympathectomy did very well for her, and now she's only on nadolol, and since August 2019, which is around 2 years now, there's nothing. Okay, so that's very good. So she never was this good. Okay. And this is some studies about the atenolol. Like I said, atenolol might work, but nadolol is the best in general. Okay, so nadolol for so here all drugs. Look, metoprolol was not significant, but all atenolol and propranolol worked okay, worked well for long QT type 1. For long QT type 2, only nadolol worked well. Okay. So for long QT type 2, nadolol is your drug of choice apparently. So nadolol, always do nadolol, or propranolol. But even if some people, even in neonates, they do nadolol. I don't usually do neonates nadolol because it's long-acting drug, and you worry about hypoglycemia and stuff. But people have done it, and no issues. So I think one day, at least during infancy, propranolol should be okay. But then beyond infancy, nadolol is probably better to switch to nadolol. Okay. And I'm not doing this yet, but I should probably change my practice. I usually wait until nadolol, until people are older than infancy, but I probably should change my practice. Okay. And this same study, yes, propranolol was good, but then and this is why I might need to change my practice, because they said for people who had already cardiac events, propranolol, on propranolol, they kept having cardiac events if they were on propranolol. However, they had less events if they were on these drugs. So this is one of the studies that was not very attractive for propranolol. But again, take home messages. Probably propranolol is best for infancy, and nadolol is best beyond infancy. Okay. So now the patient is on beta blockers. However, he or she had further symptoms, like in our patient. Cardiac sympathetic denervation is an option. Especially if ICD was contraindicated, for example, infant, there's the epicardial, you cannot do transvenous, and epicardial ICD is a big surgery for infants and with many complications. So left cardiac sympathetic denervation is a very good option for such patient population, or the family refused ICD, for example, or the family or the patient did not tolerate beta blocker. Let's say he has severe asthma, for example. Left cardiac denervation is a good option. Okay. And I don't know whether Jarrah is here or not. Is he here? I didn't see him. Okay. But hopefully, one day we'll try to be more aggressive.
Yes, I'm here. You're like,
Jarrah, you're here. Okay. So
yeah.
good. You're listening to me. So one day, hopefully, we have to be more aggressive with left cardiac sympathetic denervation. Okay. Okay.
Sure.
And thank you. And also, left cardiac denervation is useful for patients who experience breakthrough symptoms while on beta blockers or ICD, class 2A. Okay. Okay. Anyways, or in general, left cardiac sympathetic denervation could be a bridge to ICD in the very young. Okay. 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 This is the data on cardiac denervation. It definitely shortens your QTC and your appropriate frequency of appropriate shocks. And our patient, after right sympathectomy, she turned around very well. So again, we have definite good strong data about cardiac denervation. and definitely risks of events come down after cardiac denervation significantly. Okay. Okay, and especially apparently, it's especially for long QT type 1, they really respond to cardiac denervation, and type 2 less, but they do respond. This study did not have much long QT type 3 patients that they couldn't tell, but definitely, this is long QT type 1, and then, the frequency of cardiac events definitely is lower, came down significantly, okay, in this patient population. And finally, ICD, of course, for anyone who survived cardiac arrest, okay, of course, unless, let's say you have a patient who had cardiac arrest, he survived, and we think it's long QT type 1, then I might be comfortable with not doing ICD, because long QT type 1, they really respond nicely to drugs, okay? So, but otherwise, if he's like long QT type 2 or long QT type 3, probably ICD is safer, okay? ICD plus drugs, okay? But, no one would fault you if you did ICD for long QT type 1 when he presented with cardiac arrest, okay? An ICD, in any patient with drugs but having recurrent syncope or recurrent arrhythmias, of course, ICD is also recommended, okay? Okay, and ICD, was most beneficial in this study for patients with long QT type 2, females long QT type 2 with 500 milliseconds of QT interval. But just so people implant ICD in general prematurely, meaning, if, this is primary prevention ICD, meaning you implant an ICD in someone who did not have cardiac arrest or sustained VT, just had diagnosis of long QT syndrome. For example, in this graph, there were 38 patients who had an ICD, and after a couple of months, only 2 of them required the ICD, so we implant many ICDs, but they rarely are used. So this tells you that we are aggressive with ICD implantation. So we have to be smarter and risk stratify the patients better, so that when we implant an ICD, this patient would very well use it, unfortunately, but would very well might use it, okay? So, but because we're not very smart in risk stratifying patients, we often over-treat or over-implant ICD just to be on the safer side, okay? Which is fair because the data is still not present. But once we get smarter, maybe in 10, 15, 20 years from today, ICD implantation would be more tailored, okay? And here, for example, so like we said, long QT type 2 is the most patient in this study, at least, who had appropriate shocks from the ICD. And then one other modality that you might use is atrial pacing. So when you atrial pace a patient with long QT syndrome, like in our patient, I don't know who was this. So if you remember, in our patient, we also atrial paced her. If you remember, we upgraded her system. We added an atrial lead. So the atrial pacing itself definitely shorten any breakthrough, well, not shorten, decrease the mean breakthrough cardiac events, especially for long QT2. So for example, this is a mean breakthrough cardiac events per patient a year. It came down very significantly when the patient was.
I finished tomorrow morning.
That means
someone is unmuted. Can you please?
Yeah. Okay, I think I fixed it. Okay, so the blue bar is the patients.
Sorry, Mohammed, can you repeat why you use the atrial lead?
Yes. So atrial pacing is very beneficial for difficult long QT syndromes, because you want when you have a steady heart rate like 80, 90 beats per minute all the time, repolarization tends to be very stable. When you have varying heart rates, this is where repolarization gets less stable in long QT patients. Okay, so when you have when you program a patient 90 beats per minute all the time, when asleep, when awake, when exercising, no heart rate change, you give aggressive beta blocker therapy and you just pace all the time, usually they respond very nicely. And this study proved that. Okay, so when you have, these are the blue bars are the cardiac events, or syncope, palpitations, torsades. and then before atrial pacing. And then with atrial pacing, the orange bar is with atrial pacing. So for example, here, look at long QT type 2, they really responded to atrial pacing. Long QT type 1 also responded to atrial pacing, but not as much, but long QT type 2 really responded to atrial pacing. And our patient, that's why we gave her an atrial lead, because we thought, because it was very difficult, and they are opening her chest anyways, we might as well try atrial pacing. You see my point, Ayman?
Yeah.
Yeah. Okay. And
Thank
then, like you said, like we said here, look, so when you pace a little bit faster than usual, so here, they always pace more than the patient intrinsic heart rate. Okay. And then the QTC, look at the QTC, always like, the mean for long QT type 2 patients were like 510, let's say, it came down to 480, for example. And, every long QT syndrome, it came down. Okay. So atrial pacing per se is and this is a very recent study, 2021, like just now. Okay. And I actually know this. Walid is a friend of mine. I just realized that Walid is there. So yeah, he's in my clinic. Yeah. So atrial pacing is a very good modality for treating long QT syndrome. Okay. So sorry, we are. I know I talked so much. So high risk patients in general, QTC above 500. Or post-pubertal woman with type 2, infants with 2 to 1 heart block, that's a bad sign. Or, those autosomal recessive mutations, meaning they have double mutation, babies autosomal recessive, the Jervell-Lange, not baby, but the mutation is autosomal recessive, but with homozygous mutation, these are usually very bad, okay? So Jervell-Lange syndrome, 2 to 1 heart block babies, these are difficult to treat. They usually require pacemakers and many therapies, okay? Low risk patients, usually males who are asymptomatic, elder males, QTC less than 460, the mutation is in the terminal portions of the channel, not the transmembrane channel portion. And the prepubertal females usually are less risk. Our patient, remember, she was homozygous. So she had, type 2 long QT, but twice, because her mom and dad, they both had long QT type 2. So our patient is unusual because she, usually people are, married, usually people are, parents are non-consanguineous in general, meaning worldwide. So, the patient inherit one bad gene. But in our case, she inherited one bad gene, and this gene is autosomal dominant. So she had 2 bad genes and both are autosomal dominant. So imagine how bad her protein that is produced, her potassium channel that's produced is very bad, okay? So that's why she's very symptomatic, despite her being pre-pubertal. Imagine now if she, God forbid, if she gets, not God forbid, sorry, but she's 20, 25 and she gets married, I don't know what will happen to her, So, she's at risk of, she's definitely the sickest patient I have, okay? And I never had seen someone as sick as this patient. And sometimes, there are cardiac transplantation option for such patients, okay? It's rarely done, but, who knows? Maybe she's one of those who might require cardiac transplantation, okay? Because now we're out of therapy. We gave her everything, and so far so good, but we'll see what happens when she's pubertal, okay? Post-pubertal, okay? Just of note here, if you have a, patient with family history of sudden death, it should not, but this patient is asymptomatic and QTC is almost always normal, you should not give an ICD or over-treat this patient just because his cousin died suddenly. You have to think a little bit different, not like a hypertrophic cardiomyopathy where you might take this into consideration. Long QT syndrome, we don't take this into consideration. Okay, so if you remember, our patient also had was on labetalol. This was based on recommendation from Boston Children's Hospital back then, because labetalol also blocks the alpha. It's an alpha receptor blocker, and there is a case report at least of alpha blockade that also helps long QT syndrome patients. Again, the people were desperate, so they were throwing everything on her. Oral magnesium shortens QTC, and this is what we did for her. Potassium, oral potassium might shorten QTC, especially in long QT type 2. HERG is the same as KCNH2, by the way. And then, fever is a known risk factor for long QT type 2. So this patient definitely fever, or at least in her family, fever was very significant factor. And this patient herself also, when she's sick, she often has symptoms. Okay, so conclusion, you have to be detective. When you measure, avoid the tail, avoid the U wave. Okay, you respect QTC of beyond 500, below 500. Still respected, but not as much. Genetics are probabilistic tests, meaning you have to study the phenotype and then order the genetic testing, and then you have to analyze the genetic report. Okay, you have to cascade screen all first-degree family members. But most long QT patients are not like this. Most long QT patients are very stable and managed with beta blockers only. Okay, and they do very well throughout their lives. Okay, and then cardiac denervation is a very promising modality, and definitely treat difficult patients. Okay, we're done. Thank you. Questions? I mean, I hope, my take-home message here, you measure the QTC very well, okay? And take good history. That's the main 2 points, okay? And then, everyone knows how to start beta blockers for patients, but, take good history and measure the QTC very well. These are the most, deficiencies that we have. Questions? People
Thank
have
you, thank you so much, Mohammed.
welcome.
Great lecture, thanks.
Question, Ali, Mutwalli, Mirvat, Abbas, Sahar, Sumaya, Tamer, Sami. ما حد عنده question?
Mohammed, do you have statistic how many new patient per year is coming for you? Do you have statistic?
I have
personal?
around 20
for
families.
your last 3 years.
Yeah,
New
20
cases.
20 families.
20 families within last year or within last 3 years?
3 years.
Within 3 years.
Yeah.
20 families.
Around 20. Yeah, a little bit less than 20. I think 17, 18, like
And
this.
from these 20 families, how many
But they
members
were-
has ISD?
But
How
some
many
of them are
patients?
inherited, like meaning they were seeing Dr. Ali or Dr. Fawzia and they came to me, not new patients, but some of them are new. Of course. How many?
How many from
very,
them they
very
have
rarely,
ISD?
very rarely. Pediatrics, we may, this might be our only patient with ICD.
Only
Adults,
this girl.
Yeah, adults, couple. But pediatrics, this is probably the only one. Not probably, definitely this is the only one.
Only one, because I
rarely
think
use
I
ICD.
know this lady.
Yeah, we rarely use ICD.
Yeah, I think I know this
There was
lady. Yeah, I
one
know
patient-
Mohammed, exactly, I know her. But thinks last time she was treated in London before
Last
she
time,
reached
yeah,
you.
we don't do sympathectomy here, which again, Jarrah
Yeah,
is
she
listening.
did the left sympathetic. Yeah, finish,
Jarrah
I
is
remember
listening,
you
and we,
very well.
inshallah, we'll do it, right, Jarrah, soon, inshallah. No pressure,
Mhm.
Jarrah.
Yeah, yes, inshallah, soon. We can do it. It's not a issue. At least we can bring the thoracic team with us.
Yeah.
And,
But
we can do it.
and you see, Mohammed,
It's an easy operation, to be honest.
Yeah, I know.
But
15 minutes.
it's practical question. You see, everybody when they call in, they tell me, baby have syncope, baby has seems prolonged QT. But you see, by phone, you will never take any adequate clinical presentation and family history. That's why, since I think these patients should come to you and you have time to get history. Otherwise, by phone is no point,
Yeah, but not to me, because otherwise my clinic would be very overwhelmed.
No, but what is solution? Because they overloaded, and I know what to do.
I don't know,
solution.
screening, the screening clinic or whatever. I don't know. I mean,
But a lot of calls, like stupid calls, for nothing.
Yeah, I think, I
Each
don't know.
syncom they consider prolonged QT. After that, it's exactly 90 of them not correct QT. Measure and what to do in such case like that. And we come to our hospital clinic, our consultant will go to Dr. Mustafa or Mohammed Ibrahim. Halas? How it's working? How it's working? This working?
Yeah. I mean, again, I think, I don't know. I mean, we have to, of course, we have to educate.
No, that means I tell you because it's facing problems a lot, all COVID.
Of course, part of it is educating the pediatricians, the neonatologists, the non-cardiologists to themselves take good history and themselves read the ECG and then treat our own cardiologists to themselves. You know, it's not that difficult to screen you know, there are a couple of questions in syncope and then you'll figure it out, you know, just 1 minute, couple of questions. And then you will right away know it's vasovagal or not, you know. And then the ECG, of course, if let's say a person X said a QTC is 500, you measure it, and then you think it's 420, and then you're not buying the syncope, then I don't have to worry about it. Don't even speak with me because, you know, it's probably nothing. But,
yeah, but
it starts from the beginning. It's, you know, have to educate the initial physicians and then our cardiologists, and then, you know,
yeah,
and then, you know.
Doctor who is calling still, he will not never give you precisely information. I will never
Yeah.
do big information.
So
Since I will talk, you know, this is issue. And
Yeah.
doctor who is calling you at night, he's sorry, no proper information. You know, is
Yeah,
that
I know.
he?
So then you tell him
What I should do? I should send to you, but even I don't want to do this one because
well,
it should.
I mean, usually we tell them he needs an echo or a Holter or whatever. When he comes in the echo or a Holter or whatever, we ask our questions, you know. It's a screening clinic should ask these questions.
Yeah.
And then yes, Abbas is asking, yes, Nadolol is available. We use it all the time.
Nadolol is available.
Yeah. I ordered it wasn't available when I first came in, but now it's available for a while. And you know, so far so good. It's always available. It's always available. So for the past almost a year or plus. Okay, we cannot do without Nadolol. You know, we have to. It has to be available.
I saw a patient there in UK who underwent heart transplant due to low QT.
Do you know why?
Yeah,
you have.
He was resistant. They did a sympathectomy. He was on ICD with frequent shocks.
Yeah.
And even I remember in one duty, there was a false fire alarm, and he started to have Tolsad, and his ICD gave a shock to him, and then turned it back to sinus.
So maybe he's long QT type 2 then, because with a false alarm, right?
Probably.
Yeah, maybe,
yes.
Yeah, I mean, it rarely happens, and our patient, unfortunately, might be the case one day. I hope not, but might. Yeah.
They didn't put. Also, there they put they perform in the clinic standing test.
So I don't do standing test. Yeah. Good question. I don't do it just because when I was in the US and Canada, we never did it. There are groups that do the standing test, but I know that it requires a specific set of skills, and usually it exaggerates QT interval, and you have to do it so much to know which one is significant or not. But so I don't have experience with standing tests, and many people don't. There are a specific group, you know, in Europe and elsewhere that do routinely standing tests. But I never did it, and I don't think I will do it unless someone teaches me the right way of doing it. Yeah, but
they put a lot
exaggerates the QT interval. Sorry, say it again.
They put a lot of concern about the morphology of the T wave rather than the QT interval.
Yeah. Abbas is saying, what is standing test? Just standing. They do ECG while the patient suddenly stands from a sitting position. And then this usually changes the heart rate. And if you have long QT syndrome, that sudden change in heart rate prolongs the QT abnormally. Yeah. And then Ali is saying, what's normal QT? Ali, you probably came in late, I think. So, you know, just the number itself doesn't mean much, Ali. And you listen to the recording, and then you will know why. But in general, 480 above is you have to, in general, for, you know, pre-puberty 460 and above, post-puberty 470 in males and 480 in females, in general. Yes, sorry, منو قال دكتور؟
دكتور محمد، أنا دكتور ثامر.
Yeah, hello, Dr.
Thank you for the lecture, and happy Eid for all. I just have a question about the cardiac denervation, because we have no experience in such like operations.
Yeah.
So what are the post-operative precautions, like they need temporary pacing, or they need if we need any troops, what kind of troops we can
No,
use?
it's an extra cardiac surgery. You know, it's I mean, Jarrah maybe knows more than me, but you know, they might have Horner syndrome. They might get Horner syndrome and eye dryness, but otherwise, it's you know, it's just sternotomy and lateral Jarrah, right? Lateral.
Yeah, it's a no, it's not a sternotomy. It's a right lateral thoracotomy.
Lateral thoracotomy.
Actually, to be honest, not even thoracotomy, thoracoscopy.
Thoracoscopy.
And you just denervate it with with a hook, with a diathermy hook. And it's a short operation, but you need to make sure not to get that Horner syndrome and hit the sympathetic ganglia and so on. The first ganglia. So that's the issue. It's an easy operation, but yeah, it's done by a right thoracoscopy.
So yeah, so they hit, you know, they take half of the stellate ganglion and then T2 to T4. And
Exactly.
if you do it repeatedly, it's 15 minutes surgery. It's very quick. And I meant lateral thoracotomy
and heart rate will be the same or will be slower?
It changes a little bit. It changes. The heart rate changes a little bit, but there's not significant change in heart rate. But it changes because now your heart is denervated.
And the function?
Function, there's no change in function.
No change.
So the QT usually shortens. The heart rate usually a little bit changes, but not as much.
Yeah. Thank you, Dr. Mohammed.
Welcome. So, you know, ICU manager would probably be very easy. Okay. Any other questions? Good questions.
Shukran, Dr. Mohammed.
Okay. Happy Eid, everyone. Thank you. Thank you.
Great lecture, Mohammed. Thank you very much. Thank you.
Thank you. Bye.